Welcome to the Protecting Your Nest podcast. When I started this podcast, I started it because I wanted to share with the world that a life of living with chronic medical conditions is not necessary. I wanted to share the good news that if we learned that by being metabolically healthy, our chances of avoiding those diseases would be much higher. As a reminder, metabolic syndrome is when 3 out of 5 of the following are not within range. That includes a blood pressure reading, a blood glucose reading, your waist circumference, your triglycerides, and your HDL. More recently, I've been honored to help lead the outreach committee of the Society of Metabolic Health Practitioners. In that role, I hope to not only share the healing message of metabolic health, but make sure that diverse ethnic communities hear this message while encouraging research as to whether there are differences in metabolic risk and lifestyle interventions based on ethnicity. Today, I have a guest who not only understands the connection between metabolic health and chronic medical conditions, but who will also help us identify a few which may have been under our radar. Today's guest is Dr. Andrea Salcedo. Dr. Salcedo is an obstetrics and gynecology physician with Loma Linda University Faculty Medical Clinics in Loma Linda, California. She did her undergrad work at University of Southern California, attended Western University of Health Sciences College of Osteopathic Medicine of the Pacific, her internship at Mercy Hospital and Medical Center, and her residency at Loma Linda University Health. Dr. Salcedo, it is my pleasure to welcome you to Protecting Your Nest.
Hi, thank you so much. It's an honor to be here. And I just have to say, I did go to undergraduate at Loyola Marymount University, and I got my master's in public health at University of Southern California. So, just to, so that my LMU Lions don't get mad at me, I did get Marymount Jesuit trained. So.
Yeah, when you spend that quality time with people, we want to give them full credit, and I do understand completely. So, thank you for that. And guys, before we begin this engaging conversation, as a way to make sure we reach more diverse communities, Dr. Salcedo has agreed to record a version of this podcast in Spanish with my son, believe it or not, Brandon Hampton. He also hosts his own podcast, Ritmos Negros podcast, which means Black Rhythms. And he records that in both English and Spanish. And I'm so proud of him. So if you like what you hear today, or simply know someone who would prefer to hear this podcast in Spanish, we promise to have that version in your hands, in your podcast app within the next few weeks after the release of this episode. So Doc, let's get started. When I first had a chance to talk to you, it was actually after you had done a wonderful presentation with the Society of Metabolic Health Practitioners, and you did a grand rounds for the members of the society. But I also remember one of the slides in fact, the first slide you put up was a slide of your beautiful husband and 3 children. So tell us a little bit about your family.
Yeah, so I'm a wife and mother of 3 boys. I'm a board certified OBGYN and actually the granddaughter of a Mexican migrant farm worker. And so I do have a really broad perspective. My husband is a clinical psychologist as well. And I have got young kids, 3, 5, and 10 years old. And they keep me very busy. But in partnership with my husband, we do really believe in lifelong learning and reading and just outside of our comfort zone, reading outside of our field. And so that's kind of what has brought me into the field of metabolic health also, because it's not typically seen within our OBGYN field, not really typically discussed. And so it's been kind of a really nice umbrella to have as we continue to learn as much as we can. So I've got a really great family, and balance is hard, but that's always something that we're working on. So.
Yeah, balance is very hard. And in fact, I think I mentioned before we got started, I'll be spending some time with my oldest son. We're going to go check out a movie together because my youngest son had gone to a movie with one of his buddies, and my son was like, I want to go see that movie too. So I said, let's check it out. And ironically, we looked at the ratings for the movie, and the movie that his brother saw wasn't as good. So we're going to go see a different movie. But either way,
Together.
quality
Yeah,
time we will be spending
that's
tonight.
right.
So
Good.
got to do that. So, I, I want to hear a little bit about how you ended up a fan of metabolic health. As you have suggested, a lot of our colleagues, not just in obstetrics and gynecology, but endocrine, cardiology, et cetera, um, their conventional training doesn't really focus on that. I know I didn't learn much about metabolic health. So talk a little bit about how you became a fan and any personal triumphs you were able to overcome after learning how to deal with it.
Yeah. So, I think my training story is similar to a lot of us who went through conventional, medical training. And, we kind of went through it and worked as hard as we can and then finished at the finish line. And, so about 10 years ago when I finished OBGYN training, I was in a busy practice and working really hard and making a lot of money. And, I had long hours and not a whole lot of mentors. And, I just started to feel a little bit just not like myself and maybe some pelvic pain, but nothing really big. And I was able to actually find that I had a large 9-10 centimeter endometrioma, which is a sign of endometriosis. And it's a blood filled cyst on one of my ovaries. And like any good patient, I went ahead and got that addressed and I had my ovary removed. And at that point, I had one child, I was married, and we were looking to continue our family. And the hard part is, majority of us OBGYNs, once we end up removing an ovary from a patient who's still interested in childbearing, we do try to encourage them to be placed on some sort of ovulation suppression agent, kind of like birth control pills or an injection or something to save the other ovary so that the other ovary doesn't become, affected as well. And so that's really hard if you're trying to have another baby. And so that wasn't what I was interested in. I started to feel a little bit of what many of my patients are feeling, is a little bit frustrated about how we can do a better job at treating endometriosis and other gynecologic disorders. And, endometriosis is one of those disorders that is an inflammatory disorder that not very many people know what the cause is. But so, I thought, well, if what I do know is that it's an inflammatory disorder, then what can I do to figure out how to decrease the inflammation? And so I started reading this really great book. It's called Endometriosis. It's by Dr. Diane Shepperson Mills and Michael Vernon, and their insight of looking at nutrition and how that plays a role of alleviating inflammation. And so one of those things that I looked at was gluten-free and anti-inflammatory protocols. And they really did help me. I got a lot of help with that. And I started having less bloating and less pelvic pain. And so I was like, okay, there's something here, but I didn't feel completely better. And so I thought, well, maybe these are just chronic symptoms and I'm just going to have to learn to live with them. And I really was okay with it. I was still having regular periods, but it took me 18 months to try to have another baby. And we were trying, and I was not, I was 120 pounds, and thin, and I exercised. And so it was really hard to understand why things weren't working well. And so that's when I started just asking more questions, and my work life was really overwhelming for me at that time. And so I decided to make the hard choice and quit my job. and
Oh, wow.
and I left the practice and I joined a really small little one for a few months and worked 2 days a week. And guess what? 2 months later, I got pregnant. And after trying really hard. And so I thought, hey, there's something here. What do you mean? I was eating better, but gosh, the stress reduction really did help. So yeah, I got pregnant, and then I moved to my current practice, which is where I trained. And I started really cultivating what was important to me, which is teaching and research and really tough, interesting cases. and my life just flourished. And I had my son, and he did really well. And then, without even trying, we had another one, and so, which is really funny. And so it was like, wow, what a blessing. And there's something to this balance, right? And we all talk about balance, but it really just taking the risks and doing kind of what sings in your purpose and your intention, and things will come. And so when I got pregnant with my third, I ended up getting gestational diabetes. And that was also a big surprise. And all of my colleagues were laughing at me because they were like, "How are you gestational diabetic? You were
Right.
thin." And I was a little older at that time than the typical pregnant patient, but it was pretty surprising. And so I started looking into how that was. I mean, my 1 hour glucose tolerance test at 24 weeks was 197, and I couldn't understand why that was. And that's really high. And so I didn't even do the 3 hour test because I thought, well, why? That's not normal. And so I started kind of, decreasing my carbs and carb counting and trying to figure out what that was. And I realized that there wasn't a lot of really good information for young pregnant women about how to manage gestational diabetes outside of the typical ADA diet of eating 30 grams of carbs at least per meal. And I didn't even really know what those numbers were. I thought that eating quinoa with chicken
Right.
was a protein
Which is
packed
like,
lunch,
right.
and that was really kind of messing me up. So
Yeah, because it's like 40 to 50 carbs just for one serving of
that's
that, you
right.
know? I mean,
Yeah. And
it's
when I
crazy.
started becoming aware, I was realizing that my cup of quinoa had the same or more sugar than a can of soda. And
That's right.
then I
That's
become
right.
really aware of all that. And so I had a baby, and during my maternity leave, I found Jason Fung's book. And
Mm.
and then I found the Nutrition Network, and I found Diet Doctor, and those are the things that really changed my life. So here I am.
All right. I love all of those, Jason Fung, Nutrition Network, all of it. Of course, Diet Doctor, I write a monthly column with them, so love all of that. And I was laughing in my brain when you mentioned that your husband was a behavioral health professional, and then you say that you quit your job, and I'm sure that he wanted to put you in some therapy.
Yes, that's right.
He
That's
probably
right.
was on board,
That's
but,
right.
to
He was
say, "I'm
on
just
board.
gonna
He was like,
stop."
"What?"
It's like, what are you you have a pretty good job, so maybe not.
That's right. Well, you work
But,
so
but that
hard.
is
Us doctors, we work so
yeah,
hard to get to where we are, and then we have these
yeah,
ideas of what it's supposed to be like, and then when it's not, it's very jarring. And so, for me, it was a huge reset. It was actually a gift from God for me. So,
yeah. Sometimes it takes those moments and, anybody who, listens to this podcast know we lean towards low carb, but I think they would have expected your first transition with when you made your change, it would, start with this low carb approach. And you said, no, it was stress reduction. It was the stress.
that's right.
It was getting rid of the stress. And I've seen people in my practice get rid of stress and they get off their blood pressure pills almost right away.
Mhm,
So,
mhm.
so I'm really happy that you recognize, maybe by accident, that I need to focus on myself. And I'm just happy you did that. And wow. So now, when you think about things like, you mentioned Dr. Jason Fung, for example, and, you didn't mention intermittent fasting, but I'm sure that's part of what you learned. So, did you end up incorporating intermittent fasting into your whole nutritional approach? Was that part of the process as well?
Not too much, because I feel like intermittent fasting is a kind of an advanced level for where I was at, but also where my patients
Hmm.
are at too. And so, but I really do appreciate the concepts. And what very much resonated with me was Dr. Fung's commentary about how the concept of accidentally skipping breakfast or accidentally skipping lunch, and how sometimes if you're so busy or you're very focused on a good product of what you're doing, you kind of overlook those meals and the
Hmm.
concentration that comes with that. And so I started realizing that sometimes if I skip breakfast, and I do skip breakfast most days, and I have like a cup of coffee with cream or something,
Hmm.
that does really help. And I just because I'm not that hungry in the morning, but
Right. So you're
I think it's because I've already been so transitioned to ketone metabolism that I don't really. I'm
So you're
hungry.
kind of doing it, but it wasn't
That's right.
intentional.
Yeah.
You just kind of, yeah. So you don't really make a big deal out of it.
Mhm.
Yeah, I am the same way. I tend not to eat breakfast, and if I have coffee, I of course I'm not putting any sugar in or anything. And if you do some cream or some MCT oil or whatever,
Mhm.
that's fine. So that's cool. I was just curious since you brought him up, and I don't, let's talk a little bit about this whole idea of metabolic syndrome. And I just think it's important that people really think about it because so many medical conditions are kind of linked to that. And most of us think about heart disease and, abnormalities in our cholesterol and hypertension and type 2 diabetes, of course, dementia, they're calling that type 3 diabetes these days. And of course, cancer, they're doing research on, can keto help cancer, non-alcoholic fatty liver disease. Those are things that kind of come to mind. And up your alley, polycystic ovarian syndrome as a gyne professional. But what attracted me to having you on the podcast is that, I heard you when you spoke with the Society of Metabolic Health Practitioners, you talked about, what about the uterus? Is the uterus an end organ that we need to be thinking about as it relates to metabolic disease and how it affects that organ? So talk a little bit about what you learned in your research as it relates to the uterus and how having a dysfunction metabolic state can actually make the uterus sick and give you conditions like fibroid and even cancer.
Yeah, so it's kind of like a concept that I term conscious gynecology. It's looking at various components of societal and metabolic health and its impact in women at every phase of their life. And so you're right to say that polycystic ovarian syndrome is just one of the phases of a woman's life. And so what I started wondering was what happens to all the women who have PCOS in their late 30s, 40s, and 50s? And PCOS is something that we see within women who are childbearing. And then when you're finished childbearing, all that inflammation, it's chronic inflammation, and all that chronic inflammation ends up developing into in, inflammation within the gynecologic organs. And so the gynecologic organs, particularly the uterus, and I think we get a little bit focused on the ovaries, but the uterus is one big smooth muscle, which is made of the same components as like our blood vessels. And so in fact, they react very similarly. And so the components of inflammation that lead to atherosclerotic disease are also associated with the same ones that cause uterine fibroids and actually endometrial polyps, which is just kind of a proliferation of glandular cells in the lining of the uterus that can cause some heavy bleeding too. And then, all those things lead to really huge impacts on women through their life. And then all that chronic inflammation can sometimes lead to endometrial cancer. But all along the way, women have heavy bleeding. They have irregular periods. They miss work because of it. They're suffering silently because they're bleeding through pads an hour, and they end up needing some sort of medical or surgical intervention. And that leads to impacts on society as a whole as well. And so my focus is on the development of all of those gynecologic disorders truly as a condition of a lifetime chronic condition. And so, what can we do in order to prevent the development of those chronic conditions that can lead to negative societal impacts as a whole? And so that's where my research and my interest in this field comes in.
Yeah, I was very surprised when I heard your grand rounds that we hadn't really done that. Well, maybe we have. I just know in the community that I exist in, the metabolic health community, we had not talked much about the uterus as being an organ where these things can happen. And I know the uterus has a lot of control of it by hormones, right? So I know hormones are really important for the uterus. So, and I know, there are certain hormones that affect the hormones of fertility, et cetera. So talk a little bit about the impact on hormones on gynecological health as it relates to metabolic disease.
Yeah, so Dr. Hampton, when in internal medicine and primary care, we talk about end organ disease, right? And so, which is basically metabolic impact of prediabetes and hypertension on organs such as the heart, the lungs, the kidneys. And that has to do with impairment of the proliferation of blood vessels that feed all of those organs. And so, if the blood vessels that feed those organs are not healthy because of the inflammation that is related to their development, then they're going to be damaged. Well, the same thing happens to the uterus, and the uterus will go through its own quote unquote damage as well. And so, the uterus will start to develop inflammation that leads to these benign tumors called fibroids. The uterus will start to lead to thickening of the lining of the uterus, and then that will be impaired. Now, if you think about the uterus, what organ in the body regenerates as much as the uterus does? The lining of the uterus regenerates every month. And so if
Right.
if there is inflammation from metabolic disease, the lining of the uterus is surely going to be impaired. And so we do see heavy periods. We see other things called adenomyosis, which is where the lining of the uterus infiltrates into the body of the uterus, fibroids, endometriosis, all of those things that have to do with the constant regeneration of the lining of the uterus and the body of the uterus that gets impaired. Now, you mentioned hormones, and so I think among the medical community, we get a lot of referrals in OBGYN for women who want their hormones checked. A
Right.
lot of women feel kind of like a lot of shame when they come and see us because they feel like something is kind of without beyond their control of just the mere fact that their gender is a woman. And so the hard part is that yes, estrogen and progesterone do play a role in the proliferation of uterine fibroids and of course in your menstrual cycle. And once you go through menopause, fibroids and do shrink and the lining of the uterus gets smaller and you don't menstruate anymore. But really, the hormone that we're talking about is insulin. And
Not insulin
I
again. Don't
know,
say
right?
that.
It's again and again. And it makes me laugh because patients come and see me and they want their hormones checked. And of course, there's other things that can cause problems to their periods too, prolactin and thyroid and stuff. And we do a good job at evaluating those. But most of the time, those are not the problems. And so when we kind of describe the physiology of how things happen to patients and that it's not really, yes, it is estrogen and progesterone that are imbalanced, but it's insulin that is causing the imbalance to the brain and the liver that leads to these disturbances. So here we are. It's insulin again.
Yeah. And I just want to do a shout out to insulin. Insulin is not the enemy. Too much insulin is the
That's
enemy.
right.
We need insulin for so many functions in the body. And if we didn't have insulin, we wouldn't last long at all. So it's all about too much, guys. It's not that insulin's a bad thing.
That's
It's just
right.
that we live in a society where we are overly exposed to insulin from stress and diet and lack of sleep and all the things that we've kind of touched on already. So I appreciate you kind of going there with the insulin. And I also want to talk a little bit about how so many patients, they don't just come in and say, check my hormones, something's wrong with my hormones. They also say, well, I have fibroids because everybody in my family has had fibroids. In other words, they recognize that there may be some genetic connections. But my question to you is, how big of a role have you seen genetics play in your practice as it relates to these types of medical conditions?
Yeah, that's right. That's a fair question. And so I think that when you look at all of the risk factors for uterine fibroids, genes are on the bottom of the list. And so, yes, genes do play a role, but more commonly are other risk factors like obesity and nutritional components and chronic medical conditions like hypertension and diabetes. Actually, those ailments play more of a role into the development of uterine fibroids and abnormal uterine bleeding than genetics do. The hard part is that when you have that conversation with folks, families kind of tend to behave similarly, right? And so, not just for our genes, but also just our traditions and our practices as a family and things that were passed down from generation to generation that may lead to medical problems. Particularly, of course, I'm Latina, I'm Mexican American. Our quote unquote drug of choice are tortillas, rice, and beans. And so, so that does really play a role in inflammation and carbohydrates, and consuming too much of those, right? Because if you think about how much work it took to actually create those, that type of food, it was definitely well worth it after you were all done cultivating your beans and your rice and you're making your masa for your tortilla. And then, after all that work, you can, use some of those carbohydrates. But with the advent of agriculturalization and things like that, it really makes all of those kinds of foods and starches really accessible. So, and we just eat too much of
Right.
them. We just do, unfortunately.
Yeah, and you mentioned Diet Doctor earlier. So the good news is that there are some creative ways. There's a little work because you have to make
Yeah.
these things, but you can definitely be creative and make some tortillas that are less starchy because use these fancy recipes. I think about the lady who helped raise my kids. Her name was Guana Roman,
Mhm.
and she was Mexican, and I think that's one of the reasons why, my son Brandon and my other son's name is Justin. I think that's why they both speak fluent Spanish. Their dad doesn't, but because we had a wonderful babysitter who helped take care of them. But yeah, she would come and whatever leftovers we had, she'd find a way to wrap it in tortilla, and it was always
Yes,
delicious.
yes, yes, yes.
But it was just just what we did. I really miss her and enjoyed her. In fact, I think we're due to visit her, but I think that's why I really think my kids are really engaged in that Latin American Hispanic culture because of who helped raise them. So really, really fun to hear you reflect on that. So, so when it comes to when you think about gynecological conditions, which is kind of the space you live in, and you think about metabolic conditions like hypertension and diabetes, I think during your talk, you made a connection that there is an association between gynecological conditions and people who have diabetes and hypertension. Could you speak a little bit about that connection? What connection did you find in your research?
Yeah, very good question. And I think that's the key point of this talk is that the establishment of cardiovascular disease risk factors and its association with gynecologic health is actually very well established. It's when I went as far back as the 70s to understand what those connections are in my PubMed searches and Google Scholar searches. I think some of the earliest papers I ever saw were looking at inflammatory factors that cause atherosclerotic disease with uterine fibroids and how a lot of those mechanisms are very similar. And so when you keep diving and diving in, actually there are plenty of meta-analyses and observational studies that do support the association of hypertension, diabetes, and uterine fibroids. And so that's the hard part is that those associations, although well established, and also the biochemical and physiologic markers that lead to all those things are actually very well published in the literature. It just kind of depends on whether it's very exciting to talk about. And not
Mm,
only that, but as an OBGYN, we're interventionists. We really do like to deliver babies and see a nice outcome. We do like to help women with their heavy periods and give them medications and remove uterus and things like that. And that is all within our skill set. And when we have our colleagues, our primary care colleagues, refer to us for those kinds of things, we are happy to take care of them because we do know how to take care of them. What the frustrating thing for patients is that they are all looking for the why. Why did this happen? And I think that, as OBGYNs, we're really good at treating them, but sometimes some of us have, maybe not thought about the physiology of what leads to all of these events. And the physiology is very clear, and so, if we just remember the biochemistry and physiology that we learned as medical students and translate that into gynecologic health, the answers are really clear and helpful to give to the patients. And I think that's what's frustrating for patients is when they see OBGYN, they feel like, oh, here's my medication, here they offered me surgery, but they didn't really tell me why that is. And then you sometimes feel like, man, is it just my genes? And then it's kind of safer to say, I guess it is, that this is just happening to me. But, there is a role that we can play as doctors who really foster the understanding of metabolic health with helping teach patients the connections. And I think that's really the heart of it, is that we must really
Mm-hmm.
have the heart of a teacher to explain these things to patients, and then they get to decide, right? So we get to give the recommendations and about how to treat and how their body came to be in this way. But ultimately, the patients get to decide what works for them. So,
Yeah. I love that quote, "Heart of a teacher," that you just made, because whether it's your doctor or your advanced practice clinician, your pharmacist, your nutrition professional, your accountant, your financial planner, they really should be providing knowledge and then taking that with you. You walk together and you make decisions together, but you can't make decisions together if you're not being taught
that's
anything.
right.
So I think anybody that's charged with, kind of coaching us along our way, they should have the heart of a teacher. So I will take that quote with me. I like it a lot.
Yeah, for sure.
and and it sounds like we shouldn't be that surprised when we have a person with diabetes or hypertension or dyslipidemia. We shouldn't be surprised if they also have an issue with fibroids. And I think I could understand why a quick fix like a hysterectomy or hormones would make sense. And with this data that's out there, it should make even more sense for us to answer the why question. And once we know the why, we should move in the direction of, well, how do we treat the metabolic health of this
Mhm,
patient?
mhm,
Maybe it takes too long. Maybe people think that's, going to take too long. But ultimately, that's what we really should be
mhm,
doing,
mhm.
because that's going to stop the progression.
Yes.
And maybe, and just as importantly, it'll help the next generation. If I can make sure my daughter knows about this, then maybe she won't have to deal with the same outcome. So I think that that's really important. Now, speaking of daughter, I don't have a daughter, but I know that we're recording this episode a week after Mother's Day, and I want to do a shout out to you, give you a happy
Thank
belated
you.
Mom's
Thank you.
Day. And to your mom, I know we talked a little bit about your mom earlier. I want to do a shout out to her, and for all the moms listening to this podcast, I want to do a shout out to you as well. But I wanted to kind of, you mentioned this earlier, but I just want to dive a little deeper. You mentioned that there are gynecological problems that are metabolically related when you're younger, and then there's things that happen when you're older. So just to kind of clarify that a little bit, could you speak to some of the things that happen to your body when you're metabolically unhealthy when you're younger, and then contrast it to what happens when you get older? What examples can you give
That's
me?
right. So I think it starts even from menarche, which is like our first period, all the way
Mm,
through adolescence. And so, many women can remember their very first period. A lot of them even remember how painful it was, or the heavy periods that they had, and, missing school and the irregular periods that come from that, and acne and pelvic pain. And I've had many young girls with their mothers coming in, and fathers, but coming into my clinic and talking about how their little girls are on the floor crying because of the pain that's related to their painful period. And that we have the
Mm.
term for that in gynecology. It's called dysmenorrhea, and dysmenorrhea is basically painful period. And the treatment of choice for young women in that way is to give them like ibuprofen or Midol or NSAIDs, we call them. And then later, if it doesn't work, we give them, birth control pills to help reduce the lining of the uterus and decrease the inflammation. But if you think about it, it's caused by inflammation. And so what is that inflammation? And so some of the challenges I have with counseling patients is that sometimes they think, well, doctor, I've had this since I was little, like I've had painful periods since I was little. And so what are
Right.
you talking about that that's something that is, my related to my nutrition and stuff. And so that's the challenge is that, I think we were taught that healthy nutrition was historically grains and those kinds of things, and unfortunately that did a toll on young women. And it's really sad because if you think about the amount of time of that women are or young girls are out of school because they have painful periods, or they have flooding accidents where they actually have like bleeding accidents and stuff, and that can be very humiliating for young girls. And so painful, irregular, heavy periods in adolescence is really a challenge. And, part of that, and I'm not saying that this is the entire reason, because of course there are other hematologic disorders and bleeding disorders that can cause these things too. But by and large, a large reason for painful, heavy periods in a young woman, or even irregular periods in adolescence, and does have to do with, seems like, metabolic health and the inflammation that's related to the lining of the uterus that causes all those increases in something called prostaglandins. And you do need prostaglandins in order to bleed and have a period, but sometimes there are just so much of them that they do cause so much pain. And so that's what we see in adolescence. And then that goes on. If the insult is not impaired, if or repaired, like if the metabolism doesn't improve, then we go on to see it in terms of polycystic ovary syndrome, irregular periods, and then problems with infertility, because excess insulin, as we've discussed before, is a stress hormone. And if your body feels that it's under any kind of stress, then it will tell your brain it's not safe to ovulate because it's not a good time to have a baby. And so that being said, then your body will, in a protective way, prevent you from ovulating. And after a long time, that causes irregular periods. And I think most women can relate to having a stressful event in their life. Maybe they were going through finals, or, they bought a house, or someone passed away suddenly and they miss a period or two. And that's just nature's way of protecting you from having a baby during a stressful time. But after a long time, that can lead to, heavy irregular periods, periods that are unplanned. And so you have an accident somewhere at the mall or something, and so it's just really hard, and it affects women's ability to work and the type of professions that they even choose. And, and then those same women will end up maybe not ever having children, or having a one or two children, but then they also have complications during their pregnancy. And the American College of OBGYNs does recognize that if you do have gestational diabetes, hypertension, growth restriction problems with the babies during your pregnancy, also placental abruption, preeclampsia, that after you have the baby in 3 months, you should have a cardiovascular disease workup with your primary care doctor. And so that, to me, all indicates that there is some sort of uterine inflammation, likely related to the same metabolic factors that cause cardiovascular disease, present and affecting the integrity of the uterus. And so as such, we are aware of that. But the hard part is that those kinds of things are really hard to treat, right? Because they are chronic illnesses. And there's not like just one pill I can give someone. It's not like an infection where here's your antibiotic. These are hard diseases, and and then later on in life, these same women get fibroids, and they end up missing work, and because of bleeding episodes again, they end up missing work or parts of their family's lives because they needed surgery to treat them. And then later they end up with endometrial cancer. And so, it's just a kind of a lifelong thing. And it's just like chronic disease is, it's lifelong. So,
Mm. Wow.
right? That's
I
a
mean,
lot.
you you gave me the best answer ever. I am so happy you articulated it from going back to when those cycles start to getting older and having cancer. And it sounds like too much insulin, too much prostaglandin. And all I hear from listening to you is that metabolic disease includes everything that you listed and more. And what was interesting, and you're right, in some ways you're right, in some ways you're wrong. It's really hard to treat. Yeah, it is hard to treat, but it's real easy to treat in a way.
Right. That's right.
It's like, it's kind of like, yeah, if we can just get our population to understand the importance of metabolic health. And I'll be having a conversation with some leaders this week and trying to nudge them towards this idea that if we're going to help people live well, which is our model for our health system, we can't do that without putting this lifestyle stuff on the forefront. It has to be the first thing that we do, while also making sure our patients get their eye exams, while making sure they see the foot doctor, while making sure they get their hemoglobin A1C, while making sure
Mm-hmm.
that they are refilling their prescriptions and appropriately being put on medicines that make sense. So yeah, I think that we have a easy answer, but it's hard to get the ship to move in a slightly different direction. And shout out to the barking
Oh,
dog. Do you have a
sorry.
dog also? Is that your
It's
dog?
my dog.
What's his name? What's
Oh,
he or
her
she's
name
name?
is Corazon, and I think someone's coming home at, so she gets
Oh, okay,
excited.
cool.
So
Well, I love it. I want to make sure
Zoom.
we get the whole
No, we got
family.
the
So
whole family here. It's
that's right.
pandemic problems, right?
That's right. And this, I love it. So thank you. I'm glad that she acknowledged her
Yeah.
existence. So thank you for that. And let me ask you a real easy question. Maybe it's not easy, but why do you think, with all the things that you've described, and it's all metabolic health, conventional medicine seems to have missed the mark here? Why do you think that conventional medicine hasn't really taken as seriously when the studies are there? If we're not I mean, I think we're both smart, but I mean, there's smart people out there that are just as smart as us, smarter. But I mean, we can read studies. We've done that. Why is conventional medicine not doing the same and reacting to that? What's your thoughts on that?
That's a really great question. I feel like most of us really do want to understand what the root causes of all of these concerns are, and really we rely on our reading, and we're trying to be as up to date as we really can. And a lot of in OBGYN, the data and the guidelines are based on medical management, clinical management of these problems, and very little is highlighted on the development and the pathophysiology of why these things are. And so, if we have a little bit more time to kind of delve into this stuff, then we are easily able to educate ourselves about what the causes are. I mean, everything I'm mentioning is all public domain. It's all part of our PubMed searches and our own textbooks. And so, I think that a lot of times too, patients come and they want to have solutions, and we can offer many solutions. But as you alluded to earlier, chronic disease, the problems are so multifaceted that maybe some folks are just not there, or maybe the doctor is not there. Maybe we're so busy in our clinic to really spend time, and some, gosh, birth control pills really do work, and surgery really does work, and so, I think that we're all just trying to do the best we can, really, and my colleagues are so good, and they are so skilled at what they do. And but sometimes I think we just have particular interests, right? Like I know of several
Yeah.
colleagues in my group that are wonderful surgeons, and then they all know that I'm kind of like the metabolic health nerd, and so
Right.
we all kind of have our own forte, and I'm a full scope OBGYN. I do surgery, I do all kinds of stuff, but this to me is what speaks, and I feel like I can make the biggest impact. And I think it's just where folks feel like they can give the biggest impact. So
Yeah, and I think when I think about that conversation I'll have this week with my executives, a lot of it is just saying that we just need to support the entire team and have people, maybe people like me and you. We may see some of the patients who need some metabolic support, but we need to have a way to take the doc who doesn't have that training with the various organizations, the College of Obesity Medicine or the Society of Metabolic Health Practitioners, or didn't take the free course that the diet doctor offers that teaches this, and the other organizations out there. So I think Nutrition Coalition as an example as well. So let's shift just a little bit. I wanted to think about inflammation again, and when you talked about it in your grand rounds, you talked about trauma and as a cause of inflammation. I thought that was very interesting, and it really speaks to me because my NEST acronym, the T stands for trauma and how we think. And so in fact, my next guest on the podcast is going to talk about trauma. And I'm trying to make sure that people don't miss that. We're in a traumatic situation as we kind of are trying to recover from the pandemic. And I'll be talking about all types of traumas that we don't traditionally think of, like human trafficking, which I didn't know. Ironically, your family's from Mexico. Well, I think it's the Philippines, the United States, and Mexico are the top three countries for human trafficking. Who'd have known, right? And if that's true, then what kind of trauma has that been to those people? And as clinicians, we need to be aware of these things so we can ask the right questions and look for, red flags. So as it relates to the inflammation in the body, what role have you seen trauma play in terms of keeping people sick?
Yeah, that's very good, because when I reflected on your acronym too, I really do feel like we're very consistent in terms of our values and how we treat patients. And so one of the things that I do is look at all sources of inflammation with patients. And so when a patient comes to see me for gynecologic problem, irregular period, PCOS, inflammation, anything like that, I draw a circle and I put inflammation in the middle, and I think about all of the different sources that lead to that. So vitamin D deficiency, hypertension, smoking, but psychologic trauma is very well established source of chronic inflammation as well. In fact, there's a really great book, you probably know it. It's Dr. Bessel van der Kolk's book, The Body Keeps the Score. And that is written by one of the world experts of PTSD, and fascinating read, and talks about the pathophysiology of excess catecholamines, which are stress hormones that are basically triggered during the time of any kind of trauma. So like if you witnessed a car accident, or if you were the victim of a sexual assault, those excess catecholamines are there to protect you, to have you fight or flight. However, if you are not able to flight or fight, then those catecholamines do get kind of stuck in your system.
Mhm.
And those excess catecholamines are raising glucose levels, which are ready to feed your muscles to run, and of course, insulin plays a role in there too. But if you don't ever discharge those energies, then the chronic inflammation and the chronic catecholamines will still be there until you discharge those energies. And so also part of my counseling with patients and looking at their gynecologic health is to look at the role that even maybe any kind of trauma in their life can play a role in where they're at now. And so it's very important to include that in the conversation, because the context is super high yield. And some folks don't even know that they were victims of trauma too. And that's a tough conversation to have also. So, I really do think that it's a very smart thing for you to be including that in your acronym. And in terms of chronic disease as well, the data is there, and people who've had um, traumatic events when they were children do go on to have increases in chronic disease as well. The data definitely shows that. And so, I think it's very good that we include that in the conversation as well. I feel like I'm anecdotally seeing a lot of women who've had endometriosis with some sort of a trauma in their life as a child. And I'm not, there is no data to support that. I'm just kind of noticing that, in my practice as I'm having conversations with patients about that. And I think that just having an open conversation about, hey, this is kind of what we're seeing. Do you fall in any of these causes or sources of inflammation? And gosh, the data says that 1 in 4 and 1 in 3 women who have been a victim of sexual assault in their life, that's huge. And unfortunately, something that is not talked about in clinical medicine very frequently.
Very good. First of all, no, I didn't read the book. So
Oh,
I
you got to
wrote
read
it
the book. It's
down.
so
The
good.
body keeps the
The
score. I'll
body-
probably I hope they got an audio book.
yeah, I know.
So
I know.
if not, I'll torture myself. I definitely will do that. And I do want to mention also that trauma can be additive. So I call it micro traumas, right? So if you have
Mm-hmm.
little micro traumas, they can be cumulative as well, and they will absolutely impact you. I won't just have a conversation about trauma with the next podcast. I'll actually be writing an article on my low carb corner with the diet doctor. So this month there will be a article talking about trauma as well. So for those who are watching or listening, make sure to check that out. And I think to my clinical colleagues out there, it's important that the message of thinking as a patient as a in total, because if you have a patient who's had trauma and you're having conversations about low carb diets, it's probably not going to work, because you have to kind of get to those other
Right.
things as well.
Right.
If you don't address those other things, they can't focus
Mm-hmm.
on, if they
Mm-hmm.
have a dysfunctional relationship, they can't really focus on their
Yeah.
diet. They can't
Yeah.
focus on
Yeah.
exercise and stress
Mm-hmm.
reduction and sleep. So I think we are souls who are kind of thinking the same way. But again, that's because we took the time to learn a different way, and we didn't just rely on our conventional training. So another thing that we have in common is that we come from communities of color. So I'm African American, you're Mexican American, and I wanted to ask you a little bit about the impact you've seen on those communities from the perspective of the gynecological things you treat. I mean, when you mentioned the statistic earlier about fibroids, I was shocked that Caucasian Americans had such a high percentage of fibroids, although the African American number was 10% higher. So tell me about your what have you seen in practice? Does it seem to be fairly equal, or do you tend to see more in communities of color?
Yeah, I have I have a wide scope of practice. I see women who have publicly funded insurance, and then I see women who work at our hospital and are privately funded as well. And so I feel like I can speak to a wide array of kind of folks with gynecologic disorders, and we do see that women of disadvantaged communities, and of course, people of color are within that context, but disadvantaged communities seem to have worsening gynecologic health outcomes than the typical population. And so, I think does our accessibility to good nutrition, maybe SNAP food benefits, WIC benefits. Those are food supplements that are given to folks of disadvantaged communities that I think we're looking at now may not be the healthiest in terms of what we know for metabolic health, but we also do know that 50% of Latino women with gestational diabetes will be diabetic in 10 years. And I knew that statistic after I
Mhm.
had gestational diabetes, and I thought, oh my gosh, I think that's probably what lit the fire under me, was that I was like, I am not going to be a statistic. I'm a physician and I know how this works. And so, I think that was really a big motivating factor for me. And knowing that, I always offer that statistic to my patients. And the other part too is that I feel like people of color, or those among disadvantaged communities are very are used to hearing about these ailments in their families, and so many of them feel like this is just kind of like what's going to happen to me, and it's just part of it, and maybe it's genes, or that a lot of times it's just kind of what's going to happen as people get older. But I would argue that there is something that we can do about it, and that I think all the message that we have in terms of really noticing and being intentional about our metabolic health will really impact larger communities as a whole. So,
Awesome. And I think, again, as we do work, I'm going to try to do my best with the Society of Metabolic Health Practitioners and continue to reach as many people as possible, just to make sure every community hears the healing possibilities with taking care of your metabolic health. So we'll wrap up with the Nest and Rope acronym, and I'll continue to remind people what that means. And I want you to think about where you're going to focus your attention over the next year. And as you know, the nutrition aspect is starting with the Nest, the exercise, less stress, more sleep, how we think, and of course, what we just talked about, trauma. And the Rope talks about relationships and, avoiding harmful organisms and pollutants, and of course, protecting our emotions and making sure our life experiences serve us. I think this experience today with you is definitely going to serve me. So when you think about this next year, where do you plan to put your attention?
yeah, I think I'm going to put most of my attention on the nutrition setting, just because I think that it really does play a role in so many people. I think it's something that we can all easily have an awareness about. And it is really, I feel like, the biggest bang for my buck in terms of the time that I can spend with patients, but also personally. And I like to cook, and I like, to kind of take care of my family in that way, and teach them. And so I think nutrition is so important. And I think once you become intentional about your nutrition, I think a lot of the other aspects of your acronyms really do fall into place as well. So,
Yeah, no doubt about it. It's been a game changer for me, and it's kind of habit now. I don't really think about it. I just eat
mm-hmm.
the way I eat, and the things that once tempted me don't. I think about, I laugh because my medical assistant, she just happens to be Mexican too. In fact, hopefully she will teach me some Spanish. I'm working next to her every day, and her name is Denise Avalos, and my wife calls her Denise. She always gives people nicknames. I think it's really cute, but yeah, I think there were times when we're laughing because people were always celebrating something, right? And people will bring in the cupcakes and
Yes.
things like
Yes.
that, and they're doing it out of love. Now, for those who are not where I'm at, it's very tempting. For me, I just see sugar and flour, so I don't really look at it as food anymore.
Yeah.
And that doesn't mean I never engage, but for the most part, I'm not really interested like I once was. So I think that as we kind of created a healthy environment for us all to thrive and eat real food, many of these metabolic problems will disappear. So as we wrap up, any final thoughts, and how can people reach you? Do you have any social media tags or anything like that? Or are you kind of staying away from that?
Yeah, I've been really just trying to be a good doctor, and kind of contribute to the literature, and do these podcasts and stuff. I'm happy to see any patients in the clinic, and you can find me on the Loma University Health website to make an appointment. But I just try to kind of give my little piece in this way, and
That's right.
I think my children and my husband are my social media right now. I have a lot of social interaction with them.
That's right. That's old school
Yeah,
social
yeah,
media.
yeah.
I would, yeah, well, thank you. I was listening to Tim Duncan, who was one of the few that were inducted to the Hall of Fame, and
Yes.
they asked him the same question. He was like, "I have no Twitter account. I have,"
Yeah.
he said, "I'm not doing any of that." So I think that's a safe place to be. So again, really, really, really appreciate you coming on today. I think we'll be connected. I know you're going to be involved with the Society of Metabolic Health Practitioners, and we really appreciate you doing that grand round. So again, thank you
Thank you.
so much for being with me today. Thank you so
Yeah, it's a
much.
pleasure. And just thank you for the good work you're doing for both the people of color as well as just the nutrition community as a whole. I really appreciate it.
Absolutely. And guys, today's guest really has given us a reason to challenge our beliefs. Today, we now know that maybe this whole metabolic health question is bigger than we ever could have imagined. The good news is that treating metabolic syndrome doesn't really require any fancy lotions or potions. We only need to follow the protecting your nest principles, and like magic, the healing begins. So, as you ponder where you will focus your attention this year, simply consider the NEST and ROPE acronym and give those areas that need attention the attention it deserves. Each and every week, I appreciate you guys for spending time with me and my guests, and would love to hear from you. So make sure to share your thoughts in the comments section. So again, until we meet again, be safe, be well, and continue to protect your nest. And thank you so much again,
My pleasure.
Doctor.
Very nice.